So my name is Merianne, and I'm a postdoc research scientist at King's College London, the Roger Williams Institute of Liver Studies. And today I will be talking about clinical metagenomics as a tool for pathogen identification and AMR profiling. But before I start talking about this, I just want to start my talk with a segment from Alexander Fleming's Nobel Prize speech, warning us about the misuse of penicillin and how bacteria can become resistant by just exposing it to small amounts of the antibiotic. And he was not mistaken. After 12 years of its discovery, resistance to penicillin was reported, and this is also the case for other antibiotic classes. And I'm sure we're all aware of the recent published study in The Lancet, forecasting 39 million deaths by the year 2050 due to antimicrobial resistance. Now, liver cirrhosis and bacterial infection, just as to give you guys a definition of liver cirrhosis, is a severe liver condition where healthy tissue is replaced by scar tissue, often due to long-term damage like alcohol use or viral infection. And in this stage, the liver struggles to perform its vital functions, making the patient more vulnerable to bacterial infections. And these infections are a major cause of complications and significantly increase the risk of death in cirrhosis patients, whereby statistics show that the risk of death increases up to 63% every year due to bacterial infections. And also the most commonly detected infections in cirrhosis, unfortunately, fall under the critical and the high group of pathogens classified by the World Health Organization. And I'm just going to share with you a European overview on the state of antimicrobial resistance in cirrhosis. Sorry. Okay, I'll just continue. So this is a European overview of the increase in AMR and cirrhosis and it's quite striking as it goes from 2017 to 2018 from 29% to 38%. So it is by no doubt a huge concern in cirrhosis. But there are several factors that put cirrhosis patients at a higher risk of antimicrobial resistance infections. These patients are inherently susceptible to infection. They are exposed to repeated hospitalization, invasive procedures. But I think the main thing that I'd want to highlight here is that there is a lack of infection diagnostics in cirrhosis, which takes me to the aims of my study, the Rapid Infection Diagnostics and Cirrhosis study. One is to be able to characterize the bacterial infection present. Two, to identify the antibiotic treatment required. Three, if there is a bacterial infection, to identify the antimicrobial resistance profile associated to it. And I think most importantly, the aim would be for clinicians to know at what point do we stop antimicrobial therapy. This is the current state of infection diagnostics in cirrhosis. I think what I want to highlight from this figure is how much time it takes from sample to antimicrobial resistance profiling, highlighting the two main samples that I use in this study, which is acidic fluid and blood. Acidic fluid is the abnormal buildup of fluid in the tummy, and it's one of the major complications of cirrhosis. And the downfall to that is that if this fluid becomes infected, it will lead to systemic inflammation. But yes, I think that what I want to highlight is how much time it takes. It takes up to 7 days from sample to antimicrobial resistance profiling, which is a lot of time, and we cannot afford in terms of prescribing the appropriate antibiotic for cirrhosis patients. And this is why we wanted to focus on evaluating and developing and optimizing clinical metagenomic sequencing using nanopore technology as a way to identify bacterial pathogens present in a sample. And I think what's good about this technology, it sequences all of the DNA material in a given sample, which allows for an untargeted and an unbiased approach for pathogen identification. The results of the sequencing are not shared with clinicians at this point because this is still a proof of concept, but we do compare them with the standard microbiology techniques that we get from the hospital. In terms of lab procedures, this is the clinical metagenomics workflow in the lab. So it's saponin treatment to sort of eliminate human DNA and concentrate microbial DNA, and then a series of DNA extraction, cleanup, library preparation using nanopore technology, and then sequencing, and then the pathogen identification and AMR profiling is then done using nanopore supported software. Going to the results, this is still, as I said, a proof of concept, small number of samples, but what I want to show here is 23 positive blood culture samples sequenced by clinical metagenomics. And then the data here is compared to the standard microbiology testing from the hospital. What we found is that in 65% of the samples, the pathogen identified showed concordance with the standard microbiology testing from the hospital. And then in figure B, you can see the variety of pathogens detected. But most importantly, the antimicrobial resistance profiling. So from these samples, we saw 12 samples showing discordance when compared to SMT from the hospital. And I think what I want to highlight mainly is if you look at figure D, the yellow part, these samples were classified all as fully sensitive at the hospital, but using clinical metagenomics, we were able to identify a variety of antimicrobial resistance determinants from these samples. And then another thing to highlight is the time, which is figure E. The time to result using clinical metagenomics is between 10 to 16 hours happening in real time, versus up to 7 days when it comes to culturing and the standard microbiology testing procedures at the hospital. I don't think we're long from embedding this technology as into routine microbiology diagnostics, but I think we need to put a lot of effort to work together in terms of involving policymakers, bioinformaticians, and also aiming to standardize protocols before making this as a service at the hospital, because at the moment we all do different things, and I think there is a need to standardize protocol before we integrate this into routine microbiology testing. As a summary from my talk, rapid and accurate infection diagnostics and AMR profiling are extremely critical for improving patients' outcome in cirrhosis. And I was able to show that clinical metagenomics offers a faster and a more precise approach, but to be able to fully embed this as a service, I think there's a need for everyone to come together and standardize protocols and workflows. And by that, this is the end of my talk. Thank you very much for listening, and thank you for the funders and the team, and also very grateful for the patients.